Welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is meningococcal disease in Australia. I'm Andrew Baird. I'll be your moderator this evening. I'm a GP in Melbourne and a member of the Immunisation Coalition. I would like to acknowledge the traditional custodians of the various lands on which we work today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders, past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the land and water of Australia. Presenting tonight's session is Professor Robert Boy. Robert will be speaking for about 40 minutes. This should leave us with plenty of time for questions and answers. For questions and answers, please type in your questions through the Q&A button, not the chat box, and you can enter questions at any time during the session. Tonight's presentation will be recorded, so all participants will be automatically muted for the event. The event is accredited for 1 hour of CPD with RACGP and with ACROM. Please ensure that you fill out the evaluation when the webinar ends in order to receive the certificate of attendance and the CPD hours if relevant to you. Robert is an infectious diseases pediatrician. Since 2005, Robert has worked at the University of Sydney in the fields of vaccinology, epidemiology, and infectious diseases. Robert is currently a senior professorial fellow at the University of Sydney Children's Hospital. From 2005 to 2019, Robert held the position of Head of Clinical Research at the National Centre for Immunisation Research and Surveillance, or NCIRS. And Robert remains an affiliate of NCIRS. Thank you, Robert, for joining us, and welcome to you. Robert.
Andrew, thank you so much. It's good to be with you all again to talk on a topic, not just the epidemiology, but some of the clinical features too of meningococcal disease. It's something I've been working on for about 30 years. And I have to say every year something new comes up. So it is really worthwhile tuning in this time, because there's a lot more compared with last year that I want to describe to you and provoke you to think about. So we all know that the world has changed in the last 3 years with COVID. I'm not giving a talk from 3 years ago. Relax. It's changing still, and there's changes just in the last few months I want to talk to you about. We know that all of those non-pharmaceutical interventions, social distancing and masks and hand washing, made a huge difference to a host of viral respiratory infections, but also bacterial infections like meningococcus and pneumococcus and group A strep. So what we've had is these non-pharmacological measures on for nearly 2 years and then off. And during those 2 years, we incurred an immune debt. We weren't exposed to all sorts of infections, and our immune systems lost some of their memory, or they never gained the memory they were meant to have as 1 or 2 year olds. So now we're having to repay that debt, and we're getting a lot more infection in 2023. So the multiple respiratory viruses have rebounded. I could name half a dozen, but I don't want to bore you. But the thing is, not only are they occurring in winter, but off season as well. Group A strep surges have occurred in Australia over the summer. In the US, the UK, meningococcal B started rising sharply at the end of 2021 in the UK in university-age students. And they actually reached pre-pandemic levels by the end of 2021 in university-age students. So the more things change, the more they stay the same in some respects. So I've been doing research for a very long time on meningococcal disease, and a study we performed gosh, over nearly 25 years ago in teenage survivors. We looked at 144 teenagers who survived and matched controls. We published it in 2006. And what we showed were precedents, preceding illnesses or preceding events which made you more at risk. What were the risk factors compared to controls? Well, being a university or school student, having a flu-like illness, probably influenza or something similar, multiple, not one, but multiple intimate kissing contacts with multiple people, and exposure to smokers, not to smoke, it was the smokers, because they were carrying and they were coughing and they were leading to transmission of bacterial infection carriage. And then when you got a flu infection or something similar, the meningococcus invaded and caused invasive disease. So I remind you as clinicians that there are two main clinical syndromes with meningococcal disease, and it's really important that you identify a case early. You're unlikely to see more than one or two in your whole professional career. So having a clinical suspicion when something is looking like septicemia with a muscle ache, with cold hands and feet, with an early petechial rash, but remember that rash may come on late. And remember too that if it's just meningococcal sepsis, not meningitis, you won't have a stiff neck. I've seen many legal cases where people said there wasn't a stiff neck. Well, they had meningococcal septicemia, not meningitis. So be wary of that. Now, during the pandemic, we had the lockdowns, which curbed the spread of COVID-19, but other infections as well. The UK meningococcal rates reached historically low levels in 2020 and 21. And Australian rates were too very low for the first time ever in recorded history in over 30 years of surveillance. We got less than 100 cases a year. In past times, we've had up to 400 or 500 cases per year, but in both 2021 and 2021 in Australia, we had less than 100. But then the UK opened up before us, and they saw a large increase in meninge B cases in adolescents and young adults at university especially. And that was reported a year ago in the literature. So the number of cases, remember they go to university, they start the year in September, and their orientation week is September. And orientation week is really important for university students because that's when they get to know each other. And quite honestly, they have multiple oral kissing contacts often in that 1 week. And carriage rates have been recorded to go from 5% meningococcal carriage on a Monday to 25% by the following Monday. That's how much interaction there is between some teenagers at university in the UK anyway. So we saw increases in older teenagers and young people in their early 20s. And most of them were in students. So if you compared the number of cases in 15 to 19-year-olds, over 40% compared with only 10 to 15% in the previous 2 years. Now, don't look at the top table, that's boring, that's not helpful. Look at the bottom table and you can see what's happened in Australia since the 90s. And we had this huge surge at the end of the 90s, early 2000s. And then we had in 2004, meningococcal C vaccine introduced, and that disease came under control by 90% within a couple of years. But even meningococcal B, despite there not being a vaccine, also dropped during the noughties, the 2000s, by 50%. And it's interesting to reflect why, and I'll tell you what, some more in a moment. But let's take you right up to the present. Last year, in the first 3 quarters of the year, January to September, almost all disease in Australia was meningococcal B, and there were twice as many cases as the year before. So the numbers are rebounding and quite markedly. So the increase in Men B was by about 1/3, and in overall meningococcal B rates by about 1/2. Showing you the same data again, going up to 2020, you see before the last 2 years, the numbers had declined from a peak in 2017. Now, I will reflect on that peak because we had a major influenza surge that year in Australia. And if you look at the peak, it's meningococcal B, it's C, it's Y, it's W. So why should 4 different genetic types of meningococcal B all peak in the same year. Surely it can't be due to a clone of B or a clone of C, because all 4 serogroups were peaking. So you look for another epidemiological explanation, and that was the surge in influenza we had that year as well. So we've published only last year, a few months ago, data showing that all meningococcal serogroups can become more common on a background of a lot of influenza in the community. So we called it the silver linings of the pandemic playbook, and we explored reasons for reductions and increases in disease, and the reduction was clearly related to non-pharmaceutical measures. If I go on, it was also related to, in 2017-18, to the introduction of ACYW vaccination. And that came first for teenagers, then later for toddlers aged 12, 13 months as well. And it went on in 2018 onto the adolescent schedule under the National Immunisation Program. And then we had all the public health measures in 2020 for COVID-19, which I've already described. So this is a graph to show you that when we had a peak in influenza, we had a peak also in invasive meningococcal disease. And most peaks, one corresponded with the other. So it was really quite stark data. And it's not just Australia, the US epidemiologists have shown a very similar thing. So it hasn't been widely understood, but influenza tracks very well with subsequent secondary invasive meningococcal disease. So both influenza and meningococcal disease are diseases of crowding. We know that. There was a paper published at the end of the First World War 100 years ago, which talked about the impact of overcrowding on both carriage of meningococci and invasive disease. And that paper, if you go to the third point, published in 1918 in the British Medical Journal, listed 6 factors, and one of them was season. We know that winter is a bad time for flu. One of them was preceding influenza, so they knew it then already. One of them was overcrowding, another was high carriage rates of meninge. So these are things that we've confirmed in the past century, but we knew them already over 100 years ago. So what about taking us right up to the current? Well, over the last 20 years, we first of all had the rollout of meningococcal C vaccination for infants from a year of age. And then in October 2018, meningococcal B vaccination was funded for children living just in one state, South Australia, where the rates of meningococcal B disease were a bit higher. And because they also had a public health minded government who were willing to invest. And they made the rest of Australia take notice because they implemented a vaccine which was very effective and safe. Now, the rest of Australia did introduce routine meningococcal B vaccination for Indigenous children, Aboriginal and Torres Strait Islanders, infants from 2 months of age from July 2020. So we've had it now for 2.5 years. And just in the last couple of months, we've had a 2+1 schedule of meninge B vaccine introduced for 12 to 23-month-old Indigenous infants. That's a bit of fine print, but what it means is that what we would be giving before to 12 to 23 months was just 2 doses, but the antibody levels were falling too quickly. So there's a booster 6-12 months later to improve the immunogenicity and the protection. And people who have, in Australia, who have medical conditions which put them at high risk of meningococcal disease, complement deficiency, asplegia, HIV, stem cell transplant, they are strongly recommended vaccination in the ATAGI notification from just December 2 months ago. You would be interested to know that right now they're about to implement meningococcal B vaccination for all infants in New Zealand, not just Indigenous, but all. It so happens that the rate of disease in Maori and Pacifica babies is much higher, but they're introducing the vaccine for all infants in New Zealand as we speak. Their rates of disease, curiously, have been 3 times higher in New Zealand in infants compared with Australia over the last year. So they've had a big surge as well since they opened up after the COVID restrictions. So the results of non-pharmaceutical interventions and increased vaccination have been the lowest rates of meningococcal disease and influenza since national records were kept. Just to underline that point, since then, there's been a resurgence. So you can read this slide. I won't state it again. It's fairly obvious what I'm saying. And now that you've had 10 seconds to read it, I'm going to move on and show you some slides. Now, this is a paper I published with colleagues from the National Centre some years ago now. And you see that in the early noughties, 2000, 2001, 2, there was very high rates of meningococcal C disease in Australia. And then we followed the introduction of vaccination in 2003-4 with a dramatic decline in meningococcal C disease, such that by 2016, there'd been a 99% reduction, disease almost wiped out in men C, but men B was also reduced by 50%. Curious, and it may be related to influenza. I don't have a strong explanation for it, and in the discussion we may come back to that point. So I don't think that C vaccine protects against B disease, by the way. So looking from 1997 onwards, we got the National Meningococcal C Conjugate Vaccine Campaign from 2003 onwards, and you saw a major decline in disease. But 2017, I've mentioned it already, 4 different serogroups went up, and Men C was one of them. Most of those cases in that blip in 2017 were actually in men who have sex with men. And it transpired that the close physical sexual contact allowed respiratory bacteria to spread and for there to be a surge in Menin C, not as big as it was 20 years earlier, but a smaller surge, and particularly in men who have sex with men. Now, there's actually been surges worldwide in meningococcal C disease in most first world countries. And USA has had one for the last couple of years as well, especially in Florida. And they've been encouraging men to get vaccinated against meningococcal C disease, especially young men. But World Pride, the big event, is on in Sydney right now. 500,000 people are visiting from around the world, and there will be raves and other dance parties and other social occasions when people will get up close and personal, and transmission of viruses and bacteria will occur. So it's quite possible that we could see a small resurgence of meningococcal C disease in unvaccinated people, especially over the next month. Or they may take it back with them to their home country and pass it on there as well. So meningococcal B in Australia, by about 2020, there'd been almost a 70% decline since the C vaccine campaign. Really, is it that the bug itself is going away for some reason, that human immunity is improved in some way? I really don't know. But by December, 2 months ago, there was a New South Wales alert because it was coming back. All 29 new cases in 2022 in New South Wales were meningococcal B, and 10% had died. There'd been a cluster of 4 cases in Illawarra, and a cluster of another 4 at Splendour in the Grass in the central coast of New South Wales, and a case in Canberra at the Spilt Milk Music Festival. And by the same token, New Zealand too had seen that surge. Now, 69 cases, considering that New Zealand has the same population as Sydney, which is a bit over 5 million. That would mean that if New Zealand had the population of Australia, there'd be 350 cases. And most of them, 80%, have been serogroup B in the last year. And that was a 50% increase on the year before. And as I've said already, most of the cases under 5 years, 90% of them are in Maori or Pacifica children. So this disease is on the way back, and we don't know whether this year it will surge even more or not. I haven't got a crystal ball, I'm sorry. So Men B did then show after that surge in 2017 a decline, but now it's on its way back. This is interesting. When we think about respiratory pandemics, we go all the way back to 2000 we see that there was a surge in respiratory viral infection, which would have seeded some bacterial infection. But in 2017, the flu surge, the 2009, of course, was the pandemic, H1N1. 2017 was H3N2. And that, as you see in the bottom graph, led to a much bigger surge in the late winter, early autumn of meningococcal B disease in 2017. So the vaccine, briefly, has been around for over 10 years, and it came up to ATAGI, the PPAC, 10 years ago, and was suggested for the National Immunisation Program. And it was available already then by private prescription, but it did not go on the NIP because of the cost-benefit ratio being such that an expensive vaccine was not considered good enough to prevent the disease we had at that time, which was between 1 and 200 cases a year. So the PBAC in the final point rejected application on cost-benefit analysis. However, the highest rates of disease in Australia after that were in South Australia, and they took the bull by the horns and got involved with the company and did a study to introduce vaccination for teenagers in high schools. And they did an excellent piece of work, cluster randomized controlled trial, and were with the aim of not just preventing disease, but preventing carriage. Now, the study actually did not show benefit in terms of preventing carriage, but did show benefit in preventing disease, which of course is more important. But it also means that there wasn't going to be herd immunity benefits. The direct effect in immunogenicity in the vaccinated individual was good, but didn't have an impact on carriage and transmission. What about meningococcal C? I've been studying meningococcal C back since the 1990s. And it was usurped in 2000 by meningococcal W, clonal complex 11. Meningococcal W suddenly started surging around the world in sub-Saharan Africa, but also at the Hajj, the Saudi Arabian pilgrimage, where in 2000 and 2001, there were 400 cases and 52 deaths. And those adults who went on pilgrimage back 20 years ago brought the bacteria back in their throats to Australia and to the UK, where I was working at the time, and seeded disease in Europe. And in fact, I was working at the Royal London Hospital in 2000, 2001, and we had the biggest pediatric outbreak of meningococcal W because parents had brought it back as a carrier, given it to their children, and their children had not just been carriers but developed invasive disease. And we actually had 2 deaths in 2 consecutive days. So it was a real clinical challenge to recognise early enough and to intervene early enough for the sepsis, the overwhelming sepsis that we saw with meningococcal W disease 22 years ago in London. So, emphasise that. So what happened in Australia was we had a small surge 20 years ago, but then we had much more of a surge in the mid-teenies, 2015, 16, 17. And you see, if you look at this, it's broken down by age, less than 1 year, 1 to 4 years, going up to 65 plus. Over the course of a few years, we saw this surge up until 2017. And the numbers were still going up in 2017 when we had that flu outbreak. But the only place where the numbers started going down in 2017 were teenagers, and they were the only group getting vaccination at that time. So that's an ecological association, but it's an interesting observation. So in early 2018, the then Health Minister, Greg Hunt, announced that the quadrivalent ACWY vaccine would be introduced on the NIP. And what did we see within another year? A massive decline in all ages. Now, was that the vaccine? No, it could not be an immediate vaccine effect of vaccine just for teenagers. What we saw was that flu went away, and in 2018, meningococcal disease also went away because it wasn't being driven by flu. So we have to understand the epidemiology in terms of vaccination, in terms of behaviour, and in terms of whether you've caught influenza or not, and whether influenza is driving the pandemic. Meningococcal Y, it too surged, as I pointed out, in 2017, and by 2010 it got up to 5% of all cases. But then in 2016 to 20, it got up to nearly 20%. So it became more and more important, but then it went down again with non-pharmacological measures, and the numbers today in 2022 are low again. So I won't detain you talking about why. So overall, we've seen this incredible impact of the coronavirus, the measures taken to control it, and the measures taken to control it that controlled all sorts of other viruses and bacteria. Fascinating stuff. So it was said in the Sydney Morning Herald that this has never been seen before. Common illnesses wiped out, but now the headlines are common illnesses are back, and there are multiple ones. I've been called repeatedly over the last 2 months about meningococcal, about group A streptococcal. I know someone who's having surgery on a young adult having surgery on their heart today, only today, for a group A streptococcal aortic abscess. So it can give you a mild scarlet fever, but it can also give you serious diseases. And invasive meningococcal has its 2 syndromes, and group A strep, without wanting to divert this talk, has 4 or 5 different serious syndromes, which we could talk about in another talk. So thank you very much for your attention. I hope I finished quickly enough to allow plenty of discussion. I'd like comments and like questions, and I'll do my very best to answer them.
Robert, thank you so much for a fascinating and also intriguing insight and report on the state of play of meningococcal disease in Australia. Interestingly, I note we're a little bit short on questions just now, and I'm going to check to see if any have crept into our Q&A box. In the meantime, I thought I might ask a question. The topic is meningococcal disease in Australia. Robert, what about the highlights of meningococcal disease overseas? What key features distinguish us, Australia from overseas?
Well, I think we've, in a sense, got more in common than not. Meningococcal disease is driven, as I've emphasised, by prior influenza infection especially, but it's also driven by wet climates. And so places like Oregon in the northwest of the USA, Ireland, UK, they have New Zealand, they have higher rates even than Australia, because perhaps they've got more wet days. And you might ask, well, what does that do? It could lead to more crowding, people spending more time indoors, people spending more time indoors and getting more viral infection by their proximity. I don't know for sure, but I'm interested in the commonalities and also the distinguishing features that might teach us something. I think we've learned a lot just in the last 5 years that in the pride community, one of the short term, men who have sex with men are particularly at risk of more than sexually transmitted infections. So meningococcal B, which is all about transmission mouth to mouth, throat to throat, tonsil tennis, tongue to tongue, to be frank, is an issue in men who have sex with men, particularly if they have it with more than one partner. And that's the case too with teenagers who are heterosexual. If they have a single partner, their risk is much lower. So it doesn't matter if you do tonsil tennis with one person, it's when you do it with multiple people that bacteria and viruses get transmitted. So going back to the pride discussion, what we've got in the world right now over the last 8 or 9 months has been a surge in Mpox, previously known as monkeypox, a close relative of smallpox. And as a consequence, smallpox vaccination is highly protective against Mpox or monkeypox. And as a consequence, having a vaccine against smallpox will protect men who are currently in Australia for World Pride. And even if you have the vaccination 10 days after exposure, you can still get some protective effect. So that's important to know if you're a GP looking after people attending World Pride and they've had an exposure to monkeypox and they've realized that they may have caught an infection, you can actually do post-exposure prophylaxis, so to speak, with monkeypox vaccination. So talking about World Pride again more generally, there are the risk of sexually transmitted infections like HIV, and people are taking pre-exposure prophylaxis and taking other behavioural methods. And because the gay and bisexual community, men having sex with men, have been altering their behaviour, they've been doing things like having fewer partners and sharing their personal contact details with a partner, isolating when unwell, getting early treatment, because there is actually an antiviral treatment for monkeypox too. We had an editorial in the Daily Telegraph yesterday in Sydney about this, and it probably got syndicated around the country. Not that many people read the newspaper anymore. So meningococcal disease, I've talked about World Pride and infection. I think it's also important to look at the other risk group, which is young children. And I always call meningococcal B for babies. And it peaks at only 3 or 4 or 5 months of age. So there isn't very much maternal antibody that is spread from the mother to the baby. And if there is spread, it's gone in many infants by the time they're 4, 5, 6 months of age. So that's why immunisation starts from 6 to 8 weeks of age. In the UK, where meningococcal B vaccine is routine for all infants, and it will soon be routine for all infants in New Zealand, as I said, you start at 2 months of age. Now,
Yeah, that's, Robert,
that's enough for the moment.
That's excellent, and I would like to continue, but we've actually got some questions that have been submitted, so perhaps I could address those. And Sonia has she's picked up on this issue of meningococcal disease and influenza, and she wonders what's the clinical explanation for meningococcal disease and influenza co-occurring.
Well, I think, first of all, it's such a strong association across different countries and different times, but I think it's real. That's the first epidemiological observation and clinical observation. When we looked at our nearly 150 surviving teenagers back in the year 2000, we found very often that they had a prodrome of fever, cough, sore throat, and then they got the different invasive meningococcal disease within a week, where they then got symptoms of septicemia with cold hands and feet, fever, rigors, rash. So there were 2 clinical syndromes, an early predisposing viral, and then why is it? I'm answering your question. Influenza causes a pharyngitis, an inflammation of the throat. The meningococcus bacteria is sitting there already as a colonist, almost certainly, and that inflammation caused by the virus, allows bacteria to invade respiratory cells, epithelia, and to then go from there to the bloodstream to cause invasive bacterial septicemic disease. So I think it's as simple as that. I don't think we need to invoke anything more complicated than the virus setting up fertile ground for the bacteria to invade and to cause disease.
Thank you, Robert. I've got a question. This is an anonymous question, and it relates to the immunisation programs in different jurisdictions in Australia. So this is about South Australia and the introduction of meningococcal B vaccine. Why has meningococcal B vaccine been introduced in South Australia? Is this due to a proactive government, or is it because there's a higher rate of meningococcal disease in South Australia?
All of the above. I always say that to get things done, you have to have a triumvirate of groups. You need to have the medical establishment and academia. You need to have the bureaucracy, and you need to have industry who have a product that's safe and effective. And so we had, especially in South Australia, a lady who's just been a year ago the South Australian Australian of the Year, called Professor Helen Marshall, who did a fantastic job of setting up a study to address the effectiveness of the vaccine in the high school population. A lot of hard work, but it came off. It didn't show an impact on carriage, but it did show an impact on disease. So they had more disease, which drove them to want to do something about it. But they then had enthusiasts in government, in industry, in academia, in medicine. And the combination of all of those people working together, the whole being greater than the sum of the parts, led to an intervention which was effective and important and led to a change in policy. So I think that's how it came about.
Thank you, Robert. And this is a question about Victoria, and it's about the uptake of meningococcal B vaccine in Aboriginal and Torres Strait Islander children. Is the uptake high, however we define that? Do the statistics reflect that? So how's the uptake in Victoria?
Yeah, great question. I don't have the exact figures, but the indication I have is that it's not nearly high enough. I mean, it's barely into double figures as best I understand it. So it needs to be much higher. We need to close the gap. Everybody knows that. That's stating the obvious. And close the gap is about economic and physical health, economic prosperity, physical health, living a long, productive life. And somehow we need to go on improving. We've got so many more Indigenous people who are in medicine doing a great job and inspiring better healthcare for Indigenous Australians, whether they're Indigenous or not, as doctors. But we need to be more systematic. We need to be more holistic. We need to work out a way where we're addressing the health across the board, and not just one vaccination, but all vaccinations that are relevant, all educational and nutritional and other aspects. Now that makes it sound impossible, but if a systematic approach is being built, which I believe it is, and improved upon, which it needs to be, we can get to a point where uptake is better. A practice nurse needs to not look at someone and saying, oh, you need your flu vaccine, but you might need your meningococcal and your zoster vaccine if you're elderly, or if you're an Indigenous child, you might need pneumococcal and meningococcal and other vaccinations, maybe an extra booster to boot. So somehow we've got to take a more systematic, thorough approach to health, immunisation in particular, but health more generally.
Excellent, thanks. Thank you, Robert. I've got a question. This is really just a sort of a point of information question, which relates to meningococcal B vaccine after the age of 12 months. Is it still 2 doses?
Yes, that's an important practical question. It's just been recommended that instead of 2 doses 2 months apart and then stop, you give a booster 12 months later. Because what's been shown in the reviews of immunogenicity is that antibody levels fall off by about a half within a year or so. So you can pump them back up to 95 to 100% protective levels, so to speak. Not that we know the exact protective level, but up to a level that we believe is consistent with protection with a booster. So it's now, for 12 to 23 months, it's now a 2+1 schedule.
Just going back to the previous question, there's a comment from Varel. In her practice, she has sent out invitations to Aboriginal and Torres Strait Islander children and their parents, inviting them to attend for vaccination. And unfortunately, the comment is this has been without success. no one picked up the opportunity.
Well, we need community advocates who take the not the booze bus, but the immunisation bus, and collect families and bring them. But you know what else you can do? I did this back in Oxford with a practice nurse 30 years ago. We used to go to the traveller communities, and in some ways, some Indigenous communities are travel. They come in and out from the long grass, but many others are urban and don't move. But you can go to them, and you can deliver vaccination where people live. And we were doing it in the Oxford region with travellers back in the early 90s. And so that's, you have to get innovative. If you can't always take a horse to water, maybe you can bring the water to the horse.
Yeah, excellent. And Robert, here's a question. We're going back to the theme of influenza and invasive meningococcal disease. This is a practical question. What is the lag period between a flu outbreak and when we should expect to see IMD? So be on guard. What do you think, Robert?
Yeah, simple message is that if you hear flu is circulating, be aware of the possibility of secondary meningococcal. So you don't need to know the exact difference. Sure. What we found when we looked at 144 cases was it tended to be in the order of 3 to 7 days. So it was less than a week. It was short period. So the prior viral infection did its damage within days, and the meningococcus invaded within a couple of days. Now, the reason why so many people in the community are frightened silly of meningococcal disease and meningitis in general is that it's got an overwhelming clinical onset in some cases. And so you can go, as we say, from being fine at breakfast and dead by dinner. So you can literally go into septicemic shock and die in 12 to 24 hours. Now, that's not every case. Many cases last a couple of days before they come to clinical care, either emergency department or to a GP. But GPs are under the enormous task. They have the enormous task of trying to work out what's going on when it's hardest to know early in the course of the disease. And so sometimes it's helpful to review the patient the next day, or even if you've seen a patient in the morning, at the end of the day. And one of the things that I tell parents is, and GPs is I tell GPs as well, is tell the parents to set the alarm for 1 or 2 in the morning, just check on progress. Is there a rash developing? Is there some new symptom? Is there lethargy, a high fever, headache, vomiting? Some things won't be obvious unless you set an alarm and check on a child when you're worried that it might be meningococcal. Now, you don't do that for every child, but the handful where you've got a clinical suspicion, something's not quite right here, setting an alarm or asking a parent to set an alarm to check might bring them to hospital at 2 in the morning instead of 7 when they're almost dead. Excellent.
Very sound and practical advice, Robert. Very helpful. So certainly for the GPs here, that's very useful, and nurses, practice nurses too. I think we've probably expired our questions. I can't see any more in the box, so no open questions. We're up to date. I'll just ask one because I'm concerned, just to represent elderly people like myself. What's the place for meningococcal vaccination in the elderly?
Yes, well, there is a place. It can occur in older people, but it's much less common. The big surges are in the first 2 to 3 years of life and 15 to early 20s. Elderly people have presented with meningococcal, and it's worth pointing out a couple of things. One, W and Y especially can be more common in the elderly, and it might present with pneumonia instead of with meningitis or septicemia. So you have to have your antennae out in an older person who might have been a contact of a meningococcal case. And I'll talk about outbreaks in a moment if you'll let me rave on.
Yep, please.
But so be careful to recognise that meningococcal Y, which I said I wouldn't talk about much, can actually be a problem in the elderly, and it can cause pneumonia. And that's been shown in Europe and the USA as well as Australia. Now, outbreaks, I might just make a small comment about that, because we've had a surge in New South Wales. I mentioned just a couple of months ago, there was an alert about the Illawarra region and 4 cases. Well, back in August, there were 4 cases all associated with what was called Splendour in the Grass, Byron Bay, Central Coast, New South Wales. And there was a teenager, an early 20s, an infant, and a 40-year-old, and 1 death. Now, what was really, really interesting about Splendour in the Grass, and which I didn't emphasize, and I will do now, is that we thought we had a proper outbreak, 4 cases. Now, this looks worrying, they're all B. So why wouldn't they all be connected? Well, we did the genetics. Our colleagues in the lab at Prince of Wales Hospital and Liverpool and elsewhere in Sydney did the genetics and found that the 4 isolates were all unrelated. They were all men B, but they were genetically so different that they weren't part of the same clone, the same chain of transmission. Now, you might say, okay, that's good, it wasn't an outbreak. Actually, what it means is that there were 4 different chains of transmission all at the same time in a setting where there was crowding. And if you're at a concert, of course you've got crowding, thousands, but you also got people shouting, and they're spraying viruses and bacteria through shouting, and they might also be hugging and kissing too. So it was very interesting to have a pseudo outbreak, which indicated that meningococcal B was actually spreading more than you would otherwise think, because there were 4 separate streams of transmission. So for me, that's a note to pay attention, that it's come back, it's coming back, and it may be worse this year.
Yeah. That's a very useful point to end our session on. So many thanks, Robert. And many thanks, Robert, for a fascinating, thought-provoking and interesting session. We've learned a lot, and thank you for helping out with our difficult questions as well. And thank you, audience, for your sharing in the session and for your participation too. So many thanks indeed. Our next webinar is on HPV in Australia, and it's on March the 8th. It'll be presented by Angela Newbound. So please make sure you subscribe to the Immunisation Coalition newsletters to get more information. There'll be a short survey just at the end of the session. If you kindly complete that, we would very much look forward to getting your feedback on how our session has gone and what we can do differently. So all that remains is for me to thank everyone and to wish you all a good evening and stay well. Thank you.